All right, so today we're tackling a tough one. Metastatic breast carcinoma, specifically stage 4 disease.
Yeah, always a challenging area.
For sure. And, as surgeons, we're often right there on the front lines making these critical decisions about how to best manage these patients. So let's start with the initial evaluation. When we're faced with locally advanced presentation.
Right, so thinking like T3, T4 tumors, N2, N3 nodes,
Yeah,
you really got to be comprehensive with your staging right off the bat. Got to get that full picture.
absolutely. So we're talking contrast enhanced CT, chest, abdomen, and pelvis,
Yeah,
right?
can't miss that.
An isotope bone scan is critical too, of course.
Absolutely. Got to stage that bone involvement early on.
Now, how about in the setting of, say, early breast cancer,
hmm
T1, T2, N0, N1? Do we approach things differently there?
Yeah, a bit. Routine metastatic workup, not always necessary in those cases.
Right, unless there are some red flags.
Exactly. So if the patient's reporting new symptoms, or maybe there's a jump in their serum alkaline phosphatase,
Mm-hmm.
then we got to dig deeper.
Makes sense.
And then there's, PTCT with 18F-FDG
Ah, right, good point.
can be a helpful adjunct in certain situations.
Yeah.
Not always the first line, but
Mhm.
definitely something to keep in mind.
Now, once we've got a handle on the extent of the disease, it's really important to shift our focus when it comes to treatment goals, right? I mean, this isn't about cure anymore.
Yeah, definitely a different ballgame. The priorities really become symptom control, so improving quality of life, preventing those disabling complications, things like pathological fractures. And then, of course, we're always aiming for the longest possible survival, but always with quality of life at the forefront.
Absolutely. And what about systemic therapy? What are some of the key factors that guide our choices there?
Well, if we're dealing with hormone receptor positive disease, endocrine therapy is usually our go-to, particularly in those cases with, bone-only metastasis or limited visceral involvement.
Right.
It tends to be better tolerated, and it can provide really good disease control in that setting.
Now, what about when we have hormone receptor negative disease, or if endocrine therapies just aren't cutting it anymore?
Then we move towards systemic chemotherapy.
Okay.
And of course, if the patient's experiencing, a rapid decline visceral crisis, then chemotherapy is usually what we need to gain quick control of the situation.
Now, I've also heard about this concept of oral low-dose metronomic chemotherapy.
Right.
Where does that fit in?
That can be a really useful tool,
Hmm.
especially for its cytostatic and anti-angiogenic effects.
Right.
So it's like, putting the brakes on tumor growth, preventing those new blood vessels from forming, and it can often improve quality of life, without some of those harsher side effects that we see with traditional chemotherapy.
Really interesting. Now, let's talk about managing some of those specific metastatic complications. Bony metastasis, they're so common,
Yeah.
and they can really have a huge impact on these patients. So what's our approach there?
Well, palliative radiotherapy is really essential,
Okay.
especially for weight-bearing bones like your
Yeah.
vertebra, femur, to prevent those fractures from happening. And it's also very effective for pain control from, those painful bony deposits. We also often use bisphosphonates alongside radiotherapy
Right.
to strengthen the bone, and reduce the risk of those skeletal-related events.
And how about those patients who develop symptomatic pleural effusions?
Right, so that can cause significant breathlessness, really
Yeah.
debilitating. So first things first, got to do a therapeutic intercostal chest drainage,
Mhm.
relieve that pressure, and then we often follow that with pleurodesis to try and prevent that fluid from reaccumulating.
Okay, that makes sense. And then finally, the question of surgery for metastatic lesions. I mean, it might seem a little counterintuitive, but are there situations where we consider resection?
There are, in very carefully selected patients. So those with good performance status, favorable tumor biology. And in those cases, surgical resection of a solitary visceral metastasis can be something we consider. The goal there is to potentially improve long-term outcomes. But again, this is only in those specific situations where complete resection is achievable.
Well, it's been a really great discussion today. We've covered a lot of ground: key imaging strategies, treatment goals, systemic options, and managing those common complications.
For sure. It's a constantly evolving field.
Yeah. Absolutely.
Staying up to date on these principles is so crucial for providing the best possible care for these patients.
Couldn't agree more. Well, thank you for listening to our podcast. We'll see you in the next episode.